I'm going to go ahead and get started. The program is entitled Towards a New Paradigm in Preterm Birth Prevention, the evolving role of transvaginal ultrasonography and progesterone. As a CME program, I need to give you some disclosures. First of all, my name is Jason Baxter. I direct the research division for the Department of Obstetrics and Gynecology at Thomas Jefferson University here in Philadelphia. As the director of research, our department has participated in one of the trials that I'll be speaking about today. And as a participant in that trial, we received grant funding in order to complete that research. I have also served as a scientific advisor for Watson as part of their process to get FDA approval for a certain form of progesterone. The other company mentioned up here is Columbia Labs, who along with the NIH was the sponsor for this trial that I'll be speaking about at the end. Some of my educational objectives for today. I'm hoping that everyone in the room at the conclusion of this program will be able to explain the clinical burden of preterm birth. I'm hoping that you'll be able to distinguish patients at risk for preterm birth and initiate appropriate screening strategies. And I expect you'll be able to explain the data linking the impact of the short cervix with preterm birth. Finally, I expect you to be able to recognize the potential benefits of routine transvaginal ultrasound to measure cervical length in all pregnant patients and to be able to assess the risks and benefits of progesterone interventions. In simpler terms, my goals for you are to convince you, number one, that preterm birth is our greatest obstetrical problem. Number two, that a new prediction and prevention paradigm is needed because what we've been doing over the past number of decades hasn't been working. Number three, that transvaginal ultrasonography is our best tool for prediction of preterm birth. And finally, that vaginal progesterone is an important intervention for the prevention of preterm birth. As I mentioned previously, I'm hoping to finish up with enough time to answer questions, take your comments at the conclusion. I don't think it's a surprise to anyone in this room that preterm birth is an epidemic. What may surprise some people is when you look at this world map and you see that the least developed countries in the world have a 12 to 13% rate of preterm birth, whereas the most developed countries in the world have a 7.5% rate of preterm birth. When you look closer, you'll see that the two areas of the world with the highest rates of preterm birth are Africa and North America. Each year, there are 13 million preterm births in the world. 500,000 of those occur right here in this country, in the United States. More specifically, if we go on a state-based level, we see that a lot of the states in this area have an 11 or 12% rate, better than the South, where rates are as high as 13, 15, 19.6%. Something we need to figure out that New Hampshire, Vermont, and Idaho are doing, the few states that are actually below the 10th percentile for rates of preterm birth. So most of us, when we think about a preterm birth, this is the picture that comes to mind, a micropreemie, a baby in the intensive care nursery with a breathing tube, destined to be there for a number of weeks, if not months, hopefully before being able to go home from the hospital. And what most of us think about are some of the pathophysiology that goes along with preterm birth. The scary things like intraventricular hemorrhage, things that lead to cerebral palsy, lead to mental retardation, pathophysiology like bronchopulmonary dysplasia, leads to chronic respiratory disease, necrotizing enterocolitis, retinopathy of prematurity leading to blindness. While those micropreemies, those very preterm births, put a big burden on our healthcare system, much less on the families, on those infants themselves, the preterm births that are at 32, 34, 36 weeks also create a huge burden in terms of delayed neurodevelopmental outcome, in terms of increased costs, in terms of lost productivity. When we talk about the total cost in this country alone, the number is a staggering $26 billion with a B dollars every year that preterm birth costs this country. When I see these numbers, I think, what means of comparison do I have to $26 billion? I have a hard time coming up with comparisons. But if you look at things like what this country spends on stroke each year, that's about $68 billion, a similar level of magnitude. I want you to walk out of the room tonight thinking about a different paradigm for treating preterm birth. And specifically, I want you to be thinking about not treating preterm birth like we've been doing for the last couple decades on the labor floor, but instead preventing preterm birth before a woman gets to our labor and delivery units. We were focused on what we saw on a tachometer. Regular contractions, woman coming in feeling uncomfortable. That was oftentimes the first indication that something was wrong and we needed to address the issue with preterm birth. Who thinks alcohol works to prevent preterm birth? How about that ridodendron works to prevent preterm birth? Magnesium sulfate. People that use nifedipine, calcium channel blockers for preterm birth prevention. COX-2 inhibitors, Indocin. Now, do we think that prevents preterm birth, or does that help get steroids on board or help get women to a tertiary care center where we have great neonatology colleagues that can take care of those babies when they come out? I hope to argue effectively that by addressing preterm birth, by most of the lectures that you've probably heard on preterm birth, shouldn't be taking here on labor and delivery. It should take place weeks before, and we should shift our mindset from a treatment type of approach to a preventative type of approach. I want to talk for a little bit about transvaginal ultrasound, and specifically the measuring of cervical length as a tool to help better predict preterm birth. How many people routinely read transvaginal ultrasounds? Just to kind of put things in perspective, vaginal probe, which takes up more room in the vagina, speculum or a vaginal probe? Speculum. Which do our patients tolerate easier, a speculum or a vaginal probe? I would argue from rigorous controlled trials that back it up that women do tolerate transvaginal ultrasounds well and do tolerate speculums. I haven't met a patient that is always asking for those or wanting those exams, but I will say that a transvaginal ultrasound is as, if not more, tolerable than a speculum exam. When you look at the schematic here with a vaginal probe in the vagina, if you picture a fan of sound, that's all that ultrasound is. It comes from sonar. That fan of sound coming out of the end of the probe gives you an image of the cervical canal. Basically a three-dimensional tube made two-dimensional, making it easy to measure from the internal os to the external os. Again, measuring from the internal os to the external os to get a cervical length. Have people heard about other subtleties maybe of a cervical length ultrasound? Subtleties like sludge, or the moon sign, or a curve. People have maybe heard of some of those things. Funneling. What do those things mean? There's been a lot of research looking at all of these different adjuvants, and I'll boil it down to the simple terms that I can understand it in. Cervical length is the best predictor for preterm birth, bar none. Putting in sludge, moon signs, curved cervix, funneling, those don't tell me more to help predict a woman's risk of preterm birth than that cervical length alone. If we were to see significant funneling, this is not significant funneling, but if we were to see funneling, all that does is make the cervical length shorter. So we still measure that cervical length from the internal os to the external os, still just as predictive of preterm birth. Some of the landmarks, a bladder, fetal head, internal os and external os. And I want you to look at that posterior lip of the cervix. You see about the same size as that anterior lip in this view. So why do we care about cervical length ultrasound? Why am I spending so much time talking about it? It's been now 15 years since the first seminal work suggesting that cervical length, the shorter it is, it corresponds to a higher risk of preterm birth. As that cervical length approaches 0, that risk of preterm birth approaching 50%. From that same publication that J. Iams lead authored back in 1996, this slide in my mind tells us a lot. You see the red bell-shaped curve. Cervical length is evenly distributed over a bell. Average cervical length somewhere around 35 or 40 millimeters. The 25th percentile around 30 millimeters. The 10th percentile around 25 millimeters. The 5th, as you get lower, first percentile down around 12 millimeters. And with each of those decreasing cervical lengths, that risk for preterm birth increases. So what are the things we're looking for when we're trying to do a cervical length? As I mentioned before, we want to see a flatter isosceles triangle here at the internal os. We want to be able to see the cervical canal along its entire length. We want to be able to see a symmetric image of the external os so that when we place calipers here and here, we can get an accurate measurement. And we want to see equal size and density of the anterior and posterior lips of the cervix. Anyone who's done transabdominal measurements of the cervix or transperineal measurements? Some people say, well, hey, they're easier. We put ultrasound probes on a woman's belly all the time. They have their anatomy scan. We're looking at her belly. You know what? We can angle down a little bit, look at her cervix. Hey, if that'll give us just as much information, much easier. Doesn't have to take clothes off. Doesn't have to have this probe in the vagina. Problem is, it's not very accurate. Transabdominal measurements, a lot of false positives, a lot of false negatives. Number of trials have borne this out. When we look at sites that use transabdominal cervical length to screen for women with a short cervix, amazingly, their numbers are very different than other sites. They have the same preterm birth rate, too. Transperineal actually works a little better. It's actually a better approximation of a transvaginal cervical length. Unfortunately, it's messier and more inconvenient, and the patients don't tolerate it as well. When I think of some of the pitfalls of performing a transvaginal cervical length ultrasound, I think of a couple rules. A little checklist. My mind is always working with checklists. I want to measure at least 3 measurements and record what we call the shortest good measurement, where we can see the entire canal. Really, we should be spending at least 5 minutes with the exam. If the probe is in and then out, and that's it, you probably didn't spend enough time to be able to see any changes of that cervical length. Probably weren't able to get more than a couple measurements. Want to avoid a full bladder. So have a woman empty her bladder just beforehand. Avoid putting too much pressure on the probe. And want to make sure that you can see the endocervical canal in its entirety. Finally, you'd measure that portion of the canal that is closed. The standard of practice of how to measure cervical length is to put the probe in the vagina, find the cervix, then back off pressure until the screen blurs to guarantee you're not applying too much pressure on the cervix, and then move it in a millimeter or two so you can adequately visualize the cervix again. This is a pitfall here showing how you could artificially make a very abnormal short cervix look normal by pushing it closed. Who should we be measuring cervical length ultrasounds in? When you have a patient with certain conditions, you expect the perinatologist you work with to do a transvaginal cervical length ultrasound. They know their perinatologist is going to check a cervical length in those kind of patients. Prior preterm birth, any other reasons? Prior cone, prior leap, connective tissue disorder, exposure to DS, multiples. So I'm hearing risk factors for preterm birth. I had a sonographer I used to work with that said LEAP stood for Let's Endovag Every Patient. So how do you keep track of these lists of things that someone should have a cervical length measured in? How do you keep track of the risk factors for preterm birth? We came up with about 5. Is race a risk factor for preterm birth? Is age a risk factor for preterm birth? Socioeconomic status? BMI? Substance abuse? History of reproductive technologies? There are a ton of risk factors for preterm birth. Over the last couple of years, as part of a research program, we screened over 1,000 women in our ultrasound unit, measuring cervical lengths as part of a research protocol. And we kept track of their risk factors for preterm birth. When we went back and looked at them, 94% of the average low-risk women who walked in the door for an anatomy ultrasound had at least one risk factor for preterm birth. So when I talk about arguments for why we should be doing universal transvaginal ultrasound cervical length measurements, I'm hard-pressed to come up with a small group of women that don't have a risk factor for preterm birth. Someone might say, being an American, when you look at those rates at the beginning. I'm not expecting you to memorize this. I'm happy to share this with other people and other units. This is the algorithm that we're starting to use at Jefferson to perform transvaginal ultrasound cervical lengths in every pregnant patient that sets foot on our unit. This is a reality for us. We're doing it. So why are we doing it? Well, just having a useful tool or a useful prediction device is not very fulfilling in my mind if you don't have a treatment for it. And we do have a treatment in the form of progesterone. I want to talk first, though, about progesterone a little more on a bigger scale than just recent uses. Delalutin is actually hydroxyprogesterone caproate. FDA approved back in 1956, removed from the market in 1999. Not because of safety concerns, just not a demand for it. Number of studies done decades ago studying progestins in pregnancy. Delalutin was used as a medication to help prevent miscarriage, to help prevent preterm birth, to help continue a normal, healthy pregnancy. In 1990, there was a meta-analysis written by Dr. Kearse that looked at different progestogens, and the conclusion was that some of them may prevent preterm delivery, and most specifically, that 17-alpha hydroxyprogesterone caproate was the form of progestogen that was most likely to prevent preterm birth based on the studies done thus far. It's not a coincidence that that form of progesterone was then used by the maternal fetal medicine unit networks in the late 1990s and early 2000s to design a trial to treat women who had had a prior preterm birth. Taking the lowest hanging fruit. How do we identify women who are at risk for preterm birth? Let's pick the women who've had one before. Makes sense. It's a good study. How many people take care of patients on 17P? And just as a refresher for why we use it, of the almost 500 women who were enrolled, all with a prior preterm birth, all with a singleton pregnancy, and randomized between all getting weekly injections, some of which were progesterone or 17-OHP, some of which were placebo. There was about a third reduction in risk of preterm birth in those women who were receiving the 17-OHP. Again, 19 clinical centers, MFMU networks across this country, women who had a prior preterm birth, got injections, were willing to tolerate an injection every week to try to prevent another preterm birth. And those that had progesterone in their injection decreased the risk for recurrent preterm birth by about a third, similar rate at early gestational ages. Good indications for women with a prior preterm birth, current singleton. There have been plenty of studies looking at twins and triplets. Has not been shown to work. We give 250 milligrams each week, IM, start between 16 and 20 weeks and continue till term, water breaks, or delivery. It was at that same time that Eduardo de Fonseca published a single-center study in Brazil that looked at a similar group of women at risk for preterm birth, but instead of using shots, used vaginal progesterone suppositories. This was another randomized controlled trial, was blinded, and in women with again, sounds similar to the last study, women with a previous spontaneous preterm birth, some of which unfortunately had prophylactic cervical cerclage, some of which had uterine malformations, but by and large, women at risk for preterm birth, most of which had a prior spontaneous preterm birth. And of those women whose vaginal suppository was progesterone, they had a markedly decreased rate of recurrent preterm birth. How many people back in 2003 started using vaginal progesterone suppositories for their patients with a prior preterm birth? Not as many as used the injections. Why? My patients like the injections better? Not done in the United States? Done in Brazil? Can't trust it? Who knows? Eduardo was the lead author on another study, this time with a group in the UK, led by Kypros Nicolaides, and a larger multi-centered group. Said, well, if those vaginal suppositories of progesterone help prevent preterm birth in women who have delivered preterm before, let's see if we can find a group of women who haven't necessarily delivered early before. Let's look at all this information about a short cervix predicting preterm birth. Let's identify those women with a short cervix and treat them with vaginal suppositories of progesterone. The specifics are that over a number of sites, they screened over 24,000 women to find that about 2% of women who had a cervix that measured 15 millimeters or less. You'll recall 15 millimeters or less is pretty short. It's a small group of women. It's about 2%. And those women had a vaginal suppository every evening from 24 to 34 weeks gestation. Some of those were micronized progesterone, some of them were placebo. Happy to see that those women who received the vaginal progesterone had a significantly lower, about 45% lower, rate of spontaneous preterm birth and rate of any preterm birth at less than 34 weeks. It was in that setting that this summer, the last study that I'm going to talk about was published. This study was a joint sponsorship of Columbia Labs and the NIH. Columbia Labs is the maker of a vaginal progesterone gel that's been FDA approved for more than a decade for use in the first trimester. This multi-center, multinational study screened over 32,000 women, and similar to the last study I talked about, identified women with a short cervix to see who should be enrolled in the study. It identified a little over 2% that had a cervix that measured between 10 and 20 millimeters, and randomized those women to get daily vaginal gel, some of which had placebo, some of which had progesterone. The primary outcome of this study was preventing preterm birth less than 33 weeks gestation. The primary outcome for the study showed a decrease in rate of preterm birth less than 33 weeks from about 16% down to less than 9%. Remember I mentioned before in the De Fonseca study, a 45% reduction? Similar numbers, 45% reduction. And when you look at some of the secondary outcomes at other gestational ages, similar, 50% reduction and 38% reduction at 28, in other words, going earlier in the pregnancy, and at 35 weeks, going a little bit later in the pregnancy. Are we really trying to prevent preterm birth just to prevent preterm birth? We want to prevent those ugly pictures I showed before. We want to prevent neonatal morbidity. We want to prevent neonatal mortality. Preterm birth, gestational age, is just a surrogate marker for health of the baby. We want healthy kids, healthy moms. And more importantly, this study, when you look at any neonatal morbidity or mortality event, also had a reduction in the vaginal progesterone group by about 43%, a reduction in respiratory distress syndrome of 61%, and a reduction in low birth weight less than 1,500 grams of 53%. All significant reductions. So we can say that vaginal progesterone in treating those women with a short cervix improved health outcomes for babies. Since then, there have been 2 cost-effectiveness analyses published. Some people would say, well, yeah, okay, fine, that's great, made sense. At some academic research centers, you were able to find this, you were able to do these measurements. Can't happen in the real world. Can't happen in community practice. 3 of the sites in that study were here in Philadelphia, including community sites. When you put it down to dollars, for every 100,000 women screened, these studies suggested $12 million savings. Not just being cost effective, being cost savings. And at the same time, more than 400 quality adjusted life years saved. I hope that I've been able to convince you that preterm birth is our greatest obstetrical problem. Honestly, I don't think that's a hard sell. I think most of you probably came into the room believing or having a good idea that preterm birth is a major problem for us. I think most of you have seen the graphs that show the rate of preterm birth over the last couple decades steadily rising. I've sat in a lot of rooms, listened to a lot of people talk pessimistically about preterm birth, about what a vexing problem is, about the epidemic. I'm optimistic about it. I'm thrilled that over the last 3 years, we've seen a plateau in that preterm birth rate in this country. There are a number of factors that play into that plateau. No one knows exactly why, but preterm birth is a multifactorial problem. It's a syndrome. I firmly believe over the next couple of years, we will start to see that preterm birth rate go down. And it will not surprise me in the next decade to be back under 10%. One of those reasons is because I think I know that we should be measuring cervical lengths in every patient. As a principal investigator, as a site investigator for the most recent trial, I can tell you that we did all of our cervical length measurements on patients with full informed consent that this was research. We didn't tell a single patient this was standard of care. I was adamant about it. I said, I cannot say this is standard of care without knowing that something helps, that it saves money, that makes things better for a patient. Now that the trial is done, now that we have answers, we're changing to measuring universal cervical length in all patients because I believe it should be standard of care because it makes for improvement. When a short cervix is noted, we treat with vaginal progesterone to, number 1, reduce the risk for preterm birth, number 2, to improve neonatal outcomes, and finally, to save costs. Thanks so much for your attention. I appreciate it.